Live. We're live. Okay. Hello, it's Dr. Khosroabadi again. This is my third live event, and I'm excited to get this started today. We've had a ton of questions coming through our social media, so I'm going to be answering those for you guys. And I'm looking forward to this whole entire event. Just to give you guys some updates, we will be doing these live events second Tuesday of every month. So if you missed one, don't worry, you can get on the next one. I'll do them every month. Second Tuesday of the month, we're going to be doing them at 3 p.m. my time, which would be the Pacific time. So these are my favorite events. I love doing them, and I love to answering questions. Any questions that comes up, please send them to us. I have Instagram set up here. We're live on 3 different platforms: Instagram, YouTube, and Facebook. So they're all here, and I have a lot of technology around me, so everything is connected. So I'll be able to get your questions answered any way that you put them through Facebook, YouTube, or Instagram. There have been some questions that have been asked already, so I will be going through those first, and then from there we'll just answer any other questions that you may have. Again, my name is Dr. Khosroabadi. I'm a foot and ankle surgeon located in Los Angeles, California. Los Angeles, California is sunny today, so we're having a good day. I'm a foot and ankle deformity specialist. I did a fellowship in Baltimore, specializing in limb deformity and limb lengthening. So I have a lot of experience in that. Been practicing for the past 14 years in Los Angeles. I have my own surgery center, and most of my cases are just surgical cases. For the past 2 years, I have not seen most day-to-day podiatry patients, general podiatry patients. I mostly concentrate on surgical cases. So with that said, I'm gonna also introduce you guys to my trademark procedure, which is the AMI bunion procedure, which is advanced minimally invasive bunion procedure that I've been doing for the past 7 years. This procedure has been through many modifications based on patients' feedback, based on my own research, and seeing what patients like and what works and what doesn't work. So for the past 7 years, I've been perfecting it, and now basically this procedure has been the top procedure that's been done in my hand and in my surgery center. I also do metatarsal lengthening, which is for brachymetatarsia. If you have a short metatarsal, I operate on that. I've been also doing that for the past 14 years. There's 2 ways that I do that: bone grafting and also external fixation. External fixation would be something like this, which I started doing this for the past 14 years. When I left Baltimore, this is what I started doing. And for the past 2 years, I want to say, I have basically modified it, and I'm now offering bone grafting, which is a 1-stage procedure for the treatment of brachymetatarsia. So I have both options available for patients. The reason I started doing the second option, which is the bone grafting, is that patients, some of the patients did not want to have this device on their foot for about 4.5 months, because that's how long you're going to have this on. This is a great procedure. I still do it. I'm a big fan of this procedure, but there are patients who don't want to have this. And 2 years ago, I had a patient who came to me, and she worked at a bank, and she said, I cannot have this thing on my foot for 4.5 months. And I told her that, you have almost 2 centimeters of shortening, and I basically rarely do 2 centimeters of lengthening with the bone graft. 1 centimeter is something, but 2 centimeters. She said, if you can't, just do it for me. I'll be a good patient. I'll do whatever you say. So I said, hey, if you're game, let's do it. And that's how this journey started 2 years ago. I performed that, and we did a 2 centimeter lengthening, 1-stage lengthening. And that procedure has also been taking a lot of modification for the past 2 years. I have modified it based on the patient's feedback and also my findings. So now I can say that the bone grafting and the one-stage lengthening has also become very successful in my hand. And I'm talking about 2 centimeters of lengthening. So which is the longest, even with the external fixation, 2 centimeter lengthening, it's a big lengthening. So I have put in different procedures inside that one-stage procedure, which is not just lengthening the toe. You have to do tendon balancing. You have to do maintain the joint space. So I have created a joint spacer, which I make that joint spacer. It gets put into the joint. So when we do the acute lengthening or one-stage lengthening, the joint space is maintained. I remove that joint spacer in about 6 weeks. So that maintains the joint. That was one of the biggest issues with one-stage lengthening. Also, the tight tendon on top, when you do a one-stage lengthening, remain very, very tight and most often caused some jamming of the joint and also extension of the toe. The toe would be basically raising up like this. So tendon balancing and joint space creation has been added based on my findings and patients' feedback. So now I can, with confidence, I can say that both of these procedures, external fixation or one-stage bone lengthening or bone grafting, in my hand has been very, very successful. So both options are available to my patients. I think they're both great options and they both are very successful in my hand. So if the patient wants, the external fixation or the bone grafting, they're both available at Khosroabadi Institute. So with that said, basically those were my updates. And AMI bunionectomy has been something that I've been working on for the past 7 years. So patients from all over the country and even outside the country, I've had patients from 14 different countries they have come and seen me for my AMI bunionectomy, which is a very minimally invasive, advanced minimally invasive procedure that patients are able to walk the next day without crutches, very little pain, very little swelling, and that has been very successful in my practice. So today we're going to be covering both and also answering questions that you guys have asked before. So I'm going to be looking to my right. These are the questions that people have asked. So I'm going to be going through those. And then if we have time, I will definitely address anything that comes up live on my feed over here. So our first question, how long should I be in the state for the brachymetatarsus before going home? So here's a good example. This is a patient from overseas that's contacting us, and she's asking how long should she stay for brachymetatarsus surgery. So that goes to the previous talk that I just had with the external fixation and bone grafting. So it all depends which procedure are you doing. If we're doing the one-stage lengthening, I think if you stay here for about 2 weeks, when the swelling comes down, you should be able to return home. And at that point, you should basically just send me x-rays every 2 to 3 weeks, making sure the bone heals, and we'll be in contact. And there's no return needed unless you want to remove the hardware that's on the foot. Because when the bone graft is placed in the foot, there's plates and screws that I will be putting to hold the bone graft in place. So those have to be removed. I'm sorry, they don't have to be removed unless the patient wants them to be removed. So I think for patients overseas, the one stage is definitely a better way of going because there's not a lot of back and forth trips. But however, if you want to do the external fixation, you can have that as well, but you probably have to stay for about 10 days here so we can at least get through the first initial stages of the lengthening process, making sure the lengthening is happening. Then you can return home and send me x-rays and be in touch with me. All my patients, regardless, are getting my cell phone number, and they will be basically contacting me via WhatsApp if they're out of the country, or just text messages here if they're in the state. So hopefully that answered that question. So next question, when will I be able to walk, run, jump after breaking metatarsal bone graft? So this is a bone graft question. So the biggest difference between bone graft and external fixation, in my opinion, is the length of recovery. With the bone graft, once I'm done with the surgery, I come out of the surgery, the foot is going to look normal. So the shortening of the metatarsal and the toe will basically be back to normal. And at that point, the healing starts. So in about 2 to 3 months, the bone heals and the bone graft will become part of your foot. So 2 to 3 months of healing with one stage lengthening. With the external fixation, we're talking about 4.5, sometimes even 5, and even 6 months. I've had patients who have not consolidated. Basically, the new bone that's growing has not become hard enough for me to take the external fixation off. So at that point, there are times that they're in the external fixation 4 or 5 or 6 months. That can happen with the bone graft as well. If the bone is not healing or slowly healing, so that can take some time. However, as far as this question, as far as jumping, running, walking, I want to say 3 to 4 months with the bone graft. I want to say at least 6 to 7 months with the external fixation. Okay, so that's that question. Thank you for the question, by the way. How long does it take to heal after surgery? So they're not very clear what surgery is. So I'm gonna, we just went over the breaking metatarsal. So glad that previous question came up. So you already have the answer for the breaking metatarsal. If you're asking these questions about bunion surgery, most of my patients, somewhere between 8 to 10 weeks is when they go back to normal. Regardless of who cuts the bone or if you fracture a bone, any fracture that happens in the bone takes somewhere between 8 to 10 weeks, sometimes 12 weeks for it to completely heal. And for completely healed bone, like I said, 12 weeks, let's average it out, 10 to 12 weeks. So 10 to 12 weeks before the bone completely heals and you can go back to normal activities. So hopefully that answered that question for the patient. The biggest benefit of the AMI procedure, my procedure, is that all my patients are allowed to put weight on it the next day. So putting weight on it the next day is not an issue. But as far as when the bone completely heals, for you to be able to put extra pressure on it, which is biking, jumping, running, weightlifting, anything that's extra, then we have to wait for the bone to heal. The reason we do that is that if the bone does not heal and you're putting pressure on it, the movement between the segments is not going to let the bone heal properly, and then you're going to end up with a non-healing bone, which is a big issue. So we don't want to do that. We want to make sure the bone heals before we go back to any high impact activities. Let's put it that way. Why did my fourth toe shrink after having a fixator for 3 months? I don't recognize this patient, so I'm thinking she's not talking about me. I don't think I performed that procedure. But I mean, whoever did it, it happens to all of us. I'm just joking. But so she's saying her fourth toe shrunk after the fixator was removed. So let me correct that. Her fourth toe did not shrink. The metatarsal basically decompressed. What that means is the fixator pulled the metatarsal away from each other. So we grew more bone, and now it's at good length. If you don't keep this external fixation on till the bone completely heals, and you need to make sure what that means. Your surgeon needs to know what that means. If you take the fixator off quick before the bone heals, the whole entire metatarsal is just going to basically compress back down. So it will shrink because it has no strength to hold the structure in place. It's kind of like basically, let's say you put plaster on something. If you don't wait for it to heal, to basically set, and it's still soft, and you're putting weight on it, it's going to crumble. So that's exactly what happens with the bone. If the bone is not solid enough, it hasn't consolidated, that's the term we use, enough, which gives us signs on the x-ray. When I look at the x-ray, I know if the bone is strong enough or not. If your surgeon took that off very prematurely, before the bone consolidated, then all the lengthening you have achieved, it's going to basically, you're going to lose that. So that's probably what happened in this case. And I'm sorry that happened to you. It can happen. Either that, or maybe you had an accident. I cannot say it was just purely based on external fixation was being removed prematurely. It could be that you, it's traumatic. Something happened and you broke the bone, which is unlikely, but so that could be a reason as well. So thanks for that question. Very, very good question. Someone is telling me my lab coat is awesome. Well, thank you for noticing that. As a matter of fact, I have to get a new one because I'm sure you guys know I'm big into fitness. I've been big into fitness for the past few years, and slowly I'm getting bigger. So it's time for me to change my lab coat or the white coat because I'm outgrowing it. Let's put it this way. And I told my trainer I'm gonna charge you for it because he's the reason that I have to change my lab coat and I get a new one. But thank you for that comment. I appreciate it. Does elevating your feet every day help with anything? Okay. I think if you don't have any issues, if you don't have any swelling, if you don't have any pain, any kind of a cramping, discomfort, elevating probably not gonna do much for you. But if you have any issues with the swelling and maybe pain or some sort of a redness, anything cramping, then maybe elevating it will help you. But in my opinion, I am a big believer in moving and continue moving and strengthening the intrinsic muscles of the foot and the leg. So sitting around, elevating your feet and leg, it's not good because your muscles will get lazy, you'll have atrophy of the muscles, and the problem will get worse. So in the absence of pain and swelling, I would like everyone to just move as much as you can. Use your feet, use your muscles. Is it safe for someone to walk barefoot with severe flat foot? Very good question. Is it safe? It's safe, of course. But is it recommended? I don't recommend it unless you're walking on your tiptoes, so to say, on the ball of your foot. People who have flat feet, they don't have much of an arch. So basically, the way I put it is that you are driving a car without any shock absorption. So if the car has no shocks, every little bump, every little pothole, you feel it because everything just felt through the whole body from the foot to the ankle and all the way up. The arch in our feet, basically it acts as a shock mechanism. It's a shock absorber. So if you have a nice arch, then you're able to absorb the shock and be able to walk without much discomfort and much complication. But if you're flat, every time you walk, you're absorbing all the ground forces all the way up to your body. So ankle, knee, hip, even spine. So that's the reason that we don't recommend people who are severely flat-footed to walk barefoot. I would recommend any kind of an arch support, put in the shoe, and always wear that when you're walking or exercising. Females with flat feet, I actually recommend them if they don't want to wear arch supports and they don't want to wear sneakers, I tell them to have a wedge, at least wear a wedge, like a 1 inch, half an inch, because once you start lifting the heel, you are creating some sort of a shock absorption in your foot. So it is best if you're not in a completely flat shoes for females with flat feet, have some sort of a wedge, half an inch, 1 inch, 2 inch. whatever you guys want. But if you go anything above 1 inch, you don't want to wear that for a long period of time, because that's also not good. So I would say 1/2 inch to an inch would be better than barefoot for females that have flat feet. So one more series of questions. So someone is asking me if they can email me what's going on with their feet because they're from Bahrain. Of course you can. Like I said, I have patients calling me from overseas. So of course, please do, and I will try to get to them as best as I can. Other question, can you show pictures of brachymetatarsia day after surgery, but on the process? I don't know if I understand this question. Can you show a picture of brachymetatarsia day after surgery? So those pictures can vary. It could be, if you're talking about the brachymetatarsia surgery with external fixation, we have those readily available on our website. So if you go to Khosroabadi Institute, there is a section dedicated to brachymetatarsia. You can go through those and see the post-op pictures of brachymetatarsia, and also, which is with external fixation, gradual lengthening. You can also see brachymetatarsia surgery with acute lengthening or one-stage lengthening or bone graft procedure. You'll be able to see those on our website. At this point, I'm not able to do a picture-in-picture. My technology is not that advanced for me to throw up the picture right now, but maybe in the future, we'll do that, so that way I'll be able to show you guys videos and pictures from my computer. But yeah, go ahead and go to Khosroabadi Institute and you'll be able to see any of the pictures that you are requesting. So next question, did you had a patient that his feet didn't heal with the bone graft, you put it? Okay, very good question. So the question is that, have I had any patients that I put in a bone graft and the bone graft did not take or did not heal? I have not yet. I've had patients that take a little longer to heal, and maybe we had to help with the healing process, but none that has not healed, completely not healed. So what I mean by we had to help, there are times, even with the external fixation, if the bone is not healing, we have to intervene. What we do is we maybe inject some bone marrow aspirate concentrate, which is called the BMAC. Those are just basically platelets. We take them from your bone marrow, we spin it into this machine, and we get the platelets out. They're basically stem cells that we put in that space that the bone is trying to heal, and kind of like jumpstart the process, make sure the bone heals. We are also able to give patients a bone stimulator, which can help from time to time. There are times that we have to take the patient back in the OR, maybe add screw, some sort of a stability hardware to make sure if that's the issue, we can address it that way. There are times that we have to stimulate the bone by just drilling into the bone to make sure that the healing process can be restarted again. So there are times that we intervene. I have done that a few times with both external fixation and bone grafting. So none that has not healed completely, but we've had some delayed healing. So that's what I'm going to call it. Which is the best, bone graft from the patient, heal, or hip, or other? Okay, very good question. Wow, these are very good questions. In my opinion, they both work. Which one is better? I'm going to tell you guys the pros and cons, and you guys choose. Let's say they both heal. So in my hand, they both heal, no issues. When you're talking about getting the bone from the patient's own body, so the advantage is that the bone is live. So once you put the bone in, it starts the healing process immediately. And it's somewhat better environment for the bone to grow. But at the same time, the area that you're taking the bone from, not that it won't heal, it always heals. That the donor side always heals, no issues with that. But there's pain involved, especially if you're taking it from the heel. The wedge of bone is pretty significant, so about 2 centimeter by, I want to say 0.8, 0.9 millimeter width. So you're taking that wedge of bone out from the heel area. The patients are going to have pain. I want to say at least for a good 5-6 months. So not always, but I've seen that. From the hip area, the same. That area up here in the iliac crest becomes very sore for a long, long time. So I feel like it's better to get this from the bone bank, because when I get it, it actually comes in the shape of the metatarsal. I don't have to go and find the bone that's exactly that shape. And when you get it from the bone bank, it's actually from a cadaver bone. So this bone used to be live at some point, and it was donated. The body was donated and used for these purposes. So the bone has been harvested and processed. There is no living cells in the bone. So it's completely acellular. And once we transfer that and put it in the patient's foot, it takes a few weeks for the blood supply to go in, and then the healing process starts. And eventually the bone becomes your own bone, to a point that you won't be able to even tell which part was from which person. So once it completely heals, the bone becomes solid, and you won't even see the separation between those two bone segments. So I think they're both of them are viable options. Depends on your surgeon's preference. I prefer to get that from the bone bank, so I'm only dealing with one area. I don't have to worry about another area of healing and pain. So I prefer to get it from the bone bank, and I don't think there is much advantage as far as the healing process comes. All right, so very good questions. Have you ever had to deal with blood supply damage or nerve damage in surgery? So since the same person is asking these questions, I'm going to assume that this is they're talking about the brachiometatarsal. So nerve damage and blood supply has not happened in my hand. The dissection is very important. That's why you need to pick a skilled surgeon who knows their anatomy and knows how to go down to the level of the bone without damaging any blood supplies or nerves. Can that happen even in the most skilled hand? Of course it can happen. I have not had to deal with it, but it can happen because the nerve is there, blood supply is there. The blood supply to the metatarsal, it's not a big issue because you're not in that area of the blood supply of to the metatarsal, but the blood supply to the toe itself, with the extended lengthening and not dissecting properly and not considering the traction that you're creating, can damage the blood supply. I am a big believer to do minimal dissection. That's always been my goal. That's why I created the AMI procedure, basically minimally invasive. But with the brachiometatarsal, when you have to go down and bone graft, you cannot do that minimally invasively. So in that case, the surgical approach is invasive, but I still try to do minimal dissection, so that way I'm not taking too much tissue off of the bone so the bone can survive. So in a nutshell, you need to pick a surgeon who's skilled enough to do that. It can happen. I've seen it happen. I've had patients sent to me from other surgeons, or patients have called me with complications. So it can happen. So you need to make sure you pick your surgeons properly and basically study them, consult with them, get a second opinion, see their work. Sometimes you talk to the surgeon, you know how many cases they've done. Just the way they talk, you can tell if they have experience or they don't. So that's what I would recommend. Is there a possibility that a toe may shrink after bone graft? It's the same person. Please post more pictures of scars. Okay, so same questions. They're all talking about brachiometatarsal. So again, we talked about the shrinking of the toe. The toe itself does not shrink. So let me be more clear. So this part is called the toe. This is called the metatarsal. Most often, I want to say 80% of the time, when we're talking about brachiometatarsal, we're talking about the brachiometatarsal, meaning the metatarsal is short. So the toe appears to be short because the metatarsal is short. But I understand the language when your toe shrinks because the metatarsal shrinks. So that's what you see. You see the toe shrinking. So everyone calls it my toe shrunk. So it's not the toe that shrinks, it's the metatarsal. Is it possible? Yes, we just went over that, and I discussed why it would shrink. And then they want me to please post more pictures of the scar. I will do that for sure on my Instagram. If you follow me, please follow me. We will be showing you before and afters. Every Wednesday when I operate, we have a ton of before and after pictures, which it gets posted on my Instagram, so you can watch those. But just to kind of go over the scar is about, I want to say 3 inches, maybe 3.5 inches, is as long as the metatarsal is. So the scar starts from here to here. And another good question is that people ask me which one has a bigger scar. I think, let's say if you look at 2 feet, that one had the external fixation, one had bone grafting, and you compare them after a year when the scars are completely healed, they both look very similar. Because what happens is the external fixation, when it's lengthening, even though when you start it, it has 6 pins. But when you start lengthening, the 2 pins that are lengthening the bone, they're tearing through the skin. So they are actually creating a long scar. So by the time you are done lengthening, you have created a scar from this position to this position. So when you take the fixator off, the scar looks pretty good because it had time to heal during this 4.5 months. For the one-stage lengthening, the bone grafting, the scar is immediate because you made a big scar, and it looks, about 3.5 inches. So the difference is maybe 1/2 inch of the scar, and the scar with the external fixation looks like holes that tore through the skin. With the one-stage bone grafting, it's a nice clean scar, just a long scar. In my opinion, scar is not a big issue, as you guys can appreciate. If that was the issue, plastic surgeons couldn't do what they do. They do breast augmentation, they do septoplasty, they do cheek implants, but they hide the scar in areas, and the scars heal. After a year, you do have a scar, but it's not, very bad. It's not very prominent. Let's put it this way. So if someone looks at your foot, they're gonna know you had something done, whether it's external fixation or bone grafting. But after it's all said and done, don't judge it at the beginning. The first 2-3 months, you cannot judge it. Once the scar goes through its revision and it softens up and all the collagen comes back to the skin and becomes supple, the scar is not so bad. Either of these procedures, external fixation or the one-stage lengthening. So those were all very good questions. I'm gonna try to go on live now. See if there's any questions here. Okay, what type of exercises would you recommend for a sprained ankle? Okay, very good. Sprained ankle involves possibly some sort of a ligament, either overstretching of the ligaments around the ankle, overstretching of the tendons around the ankle, or a combination of both, or a tear. So I don't know which injury you've had, but or it's been something that it's been operated on. I'm just going to assume you just had an ankle sprain and there hasn't been any major damage or major tear. So in this case, the ligaments and the tendons have been overstretched beyond their capacity, and they're now sore. There are times that the ligaments tear slightly, and then they heal back up as long as you keep them immobilized. The the best strengthening exercises are strengthening exercises for tendons around the ankle. So at the beginning, I would say start basically writing the ABCD all the way up to, you know, the whole alphabet with your foot. So you're sitting and you're just doing A, B, C, D. So that's at the beginning stages of rehab or recovery. Then I would recommend getting a band, not too heavy, but these are called the TheraBand or any kind of a band, that resistant band, but not too heavy. And just do, we call them abduction, adduction. So just like swinging your foot from side to side and up and down with resistant. So that would get you a little stronger. And then you also need to get your proprioceptive also sharper and stronger. So I would recommend doing like going and standing in the door frame and making sure you know you don't fall, but just raising one leg and keeping the leg that's injured down and trying to go up on your toes and come down. And then just like balancing yourself, let those muscles fire up and get stronger. There are also these uneven like half ball or plates that I've seen at gyms that you can go stand on it and it just makes you really shaky. And so those really are good. Those are good for the later stages of the rehab to get those muscles and the ligaments really strong. So that's what I would recommend. Can my bunion have formed from playing too much basketball? Very good question. So I think extra activities or activities that would put your foot in a position of extra pronation can exacerbate the problem, but it cannot create a bunion. I know that studies have shown that most bunions, I want to say 95% of bunions are hereditary. So it came down the genes, so either your parents or grandparents. So it's hereditary, so it's there. But as far as how bad it gets and how severe it gets, it can also be genetic, but you can exacerbate the problem, such as wearing very narrow high heels, which would put your foot in a certain position that your toes are just jamming and your joints are just basically buckling. So those activities can exacerbate the problem. Basketball, on the other hand, I don't think so, because basketball, you're wearing very comfortable shoes and you're most often on your ball of your foot because you're jumping and running. No, in my opinion, it has not made your bunions any worse, and it has not, definitely has not developed your bunions. So very good questions. So what's the difference in the cortisone and the PRP injection? Okay, another good question. So cortisone injection is basically a steroid injection. What we do with steroid injection, we're trying to decrease the inflammation. So that's usually our first line of treatment for any kind of an injury where there is a lot of inflammation. Usually at the beginning stages of an injury, we like to inject cortisone so that way the inflammation is reduced, or it has so it can calm down. PRP is actually the opposite. We're trying to bring inflammation and healing power into the area. So what the PRP does, it's basically stem cells from your own blood. We take some venous blood from you and spin it into the machine and extract the platelet-rich plasma. That's what that means. And we inject it into the area. What that does is it brings more inflammatory cells and basically it gives it more repair power to the area. So it increases the inflammation. That's why when I do PRP, I tell my patients, do not take any anti-inflammatory medications such as steroids or ibuprofen or anything like that, because we don't want to stop inflammation. We want to bring a lot of activities and a lot of healing power to the area. So that's why PRP is completely different than steroid injections. So those are the questions that I can see, I think, from YouTube. I don't have any questions from Facebook. I'm going to check with my social media
Yeah.
expert.
You've got some last minute questions on Instagram.
On Instagram. Okay. Yeah. If you can pull those up. Yeah. If you can pull those up so I can answer them. You can go from that side and let's see if I can read them. We have a TV on this side, which is showing us the Instagram feed. So I have to look to my side, but I can also see them right here to see if there's any questions here. All right. So let's see. Can you read them to me actually?
Yeah. What is the rehabilitation after removing the pin from brachiometatarsal surgery?
After removing the pin. Okay, so I am assuming that the patient is talking about the one stage. Talking about the external fixation because they're talking about the pin. But I could be wrong because I put a pin in my one stage procedure, which is a Steinman pin going through the toe. So I'm going to answer both. So hopefully it answers this patient's question. So once the pins come out, external fixation comes out, depending on the patient's ability to walk and strength of the patient, because 4.5 months of having this device on your foot, you haven't moved your toe, it's very weak. So at the same time, there could be some issues with the joint because you haven't moved it for such a long time. So physical therapy might be a good idea. Some patients might not need it. Some patients need it. But definitely physical therapy to just increase range of motion in the joint, to get the joint going. Also strengthening the tendon, because have in mind, the tendon, the tendon's growth or the size of the tendon is exactly the size of the metatarsal, which is when you were 8 or 9 years old. That's when the metatarsal stopped growing. Your toe is at that stage. Your metatarsal is at that stage. Your tendons are exactly at that stage. When I open the foot, I see the difference between the tendon of the brachiometatarsal foot, the bone, and the adjacent bones. It's at least half a size, if not 1/3 of the size. So it's very tiny tendon. So now that we lengthen the bone, the foot appears normal, but the tendon, we cannot increase the size of the tendon. That can happen in years, but I don't even think it's going to ever come back to normal. So this toe will always be a little weaker than the other toes. That's just the way it is. But it's not really that important as long as you have control over it. It's not the major toe. It's not your big toe when you're pushing off. So strengthening that tendon, it's definitely beneficial for rehab, and also range of motion would be beneficial. So hopefully that I answered that question.
Yeah, you got some more questions as well.
Sure, go ahead.
So you have Steffi saying, could you fix my forefoot that lost length after the fixator was removed too soon?
Absolutely. So depending on how long it's been since your fixator has been removed, we have to evaluate and see if the bone that collapsed. So that's essentially what happened. The external fixation was removed too early, the bone collapsed. Now, has that bone that collapsed healed completely or not? It's best for that bone to be healed. It's easier to deal with it because now it's a solid bone and we can lengthen again. But if it's just recently happened, I have to see the condition of the bone, because when you're not putting weight on your foot for 4.5 months, let's say 4 months, and prematurely the external fixation was removed, your bone has slight osteopenia look to it, and condition is also a little bit osteopenic because you haven't put much weight on this foot. So the bone is a little weaker. So it case by case, it's different. I have to see the x-ray to see what's the condition of the bone, but it can definitely be repaired. That's actually 30% of my practice is dedicated to revisions from failed surgeries by other surgeons in this country or other countries. So it can definitely be done. Next question.
We got some more. Why the new less invasive brag is less common if it is better and faster than the old one?
Brachiometatarsal?
Yeah.
Okay, good. Well, one reason is not a lot of doctors are doing it. I for sure don't know anyone who's doing one stage past 1 centimeter of shortening. So if your metatarsal is 1 centimeter short, then a lot of doctors, surgeons are able to do the one-stage lengthening. But once it's past 1 centimeter of lengthening, not a lot of people doing it. I don't know anyone that does it besides me. So because of the complications of it, like I said, thank God I got into it with a patient who really pressured me to do it, and she was on board to make it successful, and she stuck with me, and I thank her for it. But I got a lot of insight of going beyond 1 centimeter. What are the complications? Because once you go beyond 1 centimeter, you're going to have joint issues, you're going to have tendon tightening issues, you're going to have toe basically jamming issues going either upward or downward. So that's why not a lot of doctors do it. Not a lot of surgeons want to do one-stage lengthening. And most brachymetatarsius are basically they're short more than 1 centimeter. So I want to say 80% of them are more than 1 centimeter short. So that's why you don't see anybody doing it. So I started doing this 2 years ago, and I've done at least 20, 25 cases for the past year and a half, 2 years. So hopefully it becomes more and more relevant, more and more, what do I want to say? More and more, I can't say the word, I just forgot. But anyways, hopefully more doctors become trained to do this. At this stage, I only know one, me who's doing it more than 1 centimeter of lengthening in one stage. I am writing a paper on this with everything that I've done and what I've learned and what to make this procedure successful. So hopefully that gets published soon and other surgeons can read it and find out how to do it. Am I saying it's a better procedure? No, but I think having both procedures, both options available to you, it's definitely better than just one option, because some patients don't want to have the external fixation on their foot for about 5 months. So anyways, hopefully that answered that question.
Yeah, I believe you have more.
More, okay, go ahead. We got about 13 minutes. Okay. Yeah, Instagram is the only platform that does not let us combine the streaming. So we're streaming directly to Facebook and YouTube in one platform, but Instagram, we have to set up another camera and completely separate. So Instagram doesn't let us do that. So that's why we have multiple cameras and multiple TVs running at the same time. Okay.
Next question, which is best? Bone graft from the patient's hip, heel, or other?
I answered that question. So that question was already addressed. Is that it?
Yeah.
Okay. So yeah, I mean, I already answered that questions. Both of those questions that was asked about the bone grafting. So yeah, I prefer the cadaver bone because I don't have to deal with another area of bone healing, but it's available. You can choose whichever one you want. Your surgeons can choose whatever they feel comfortable. So a couple of housekeeping announcements. We are doing this, I said it at the beginning, we do this live event every Tuesday, every second Tuesday of the month. So hopefully if you haven't been logged in right now or you forgot to submit your questions, you can hop on the next one. If you know anyone who wants to join us on these Tuesdays, please let them know. We will distribute our marketing material to let you guys know what those dates are. If you go to our website, you will see the live events. We'll be posting those dates very soon, so that way you can see when we're going to be on live. So as far as
You actually have a couple more questions if you want to check your computer screen.
Okay, oh yeah, there's a couple more that just came in. We got another 10 minutes to go. Very good. What rate do you distract for brachiometatarsial cases each day? So yeah, I played around with different rates, and I think 0.5 millimeter a day is a sweet spot. But then again, everyone is different. That's when you, as a surgeon, you need to be involved, very closely involved with your patients. They have to communicate with you, and you have to see x-rays every 2 weeks. There are times that I let someone lengthen 0.5 millimeter a day, and I see them going too far, and meaning they haven't built much bone. They're lengthening, but there's not a lot of bone growth. We call it the regenerate bone. There's not a lot of regenerate bone growth. So at that point, I slow the patients down. I take them back to 0.25 because then they're going at a rate that they're not going to grow bone. So you need to know, you need to be able to look at the x-ray and say, this is too fast or it's too slow. So there are times that it's too slow. Like I just had a patient 2 weeks ago that we went too slow, and she was almost consolidating, meaning if you wait too long, if you're not distracting enough, the bone becomes hard and you cannot distract it. So there's a sweet spot, which it is 0.5 millimeter a day in most patients, but there are times that you need to modify that. You can go faster or slower. So that's why you need to see x-rays every 2 weeks to decide if you're going too fast or you're going too slow. So it's not just a one size fit all. So hopefully that answered that questions. Will the toe always rise if the fixator does not have pins on the toe? I have noticed most fixators do not have the extra pins. Very good question. So in my opinion, if you're lengthening over 1 centimeter, that toe will have issues if you're not expanding the fixator to the toe. So for the past 14 years, when I've been doing this, the first few years, we were not putting this last sandwich clamp. So these are called the sandwich clamps, and each sandwich clamp has 2 pins that goes into the bone. The first 2 sandwich clamp is responsible to lengthen the metatarsal. The third sandwich clamp is basically to just maintain the joint space. So it's basically taking the joint space and maintaining the joint space, and at the same time, it's going along with the fixator, meaning these 2 lengthening the bone, these 2 maintains the joint space. If you don't have this sandwich clamp, when you're lengthening, you're jamming the joint. And that used to happen a lot more frequent, but now most doctors who are well-trained and they read articles, they know that this sandwich clamp has been created just to keep the joints healthy and also maintaining the joint space. So the reason you don't see it, because your surgeon is opting not to put it in, and maybe because you have not much lengthening to do. But in my opinion, if it's more than 1 centimeter, it's absolutely needed to put that third sandwich clamp. So because you're going to run into joint issues at that point. So that was one question. And then, so they're talking about most fixators do not have the extra pins. So the external fixations that I use, it's a rail device. This is just a mini rail. And you can put as many sandwich clamps as you would like on this rail system. You can even put 4 if you want to. So if you're talking about the ones that are already pre-built and they kind of look like a cylinder, they just come with 4 pins. And in my opinion, those are not good options for patients with brachiometatarsial that have more than 1 centimeter shortening. Up to 1 centimeter, you could probably get away with not creating an issue in the joint. But if it's more than that, you need the third sandwich clamp. Having this in mind, that these external fixations were not created for this condition. These external fixations were created to stabilize bones and also to manipulate the bones anywhere else, in your wrist, in your hand, small bones. These fixators work. It's not just made for the foot. There has not been any external fixation for the purpose of breaking metatarsal. I'm in the process of designing something with a company right now. So hopefully if that goes through, then that would be one of the first fixators that was created just specifically for this condition, which has all the bells and whistles. It's going to do a superior job. These will do it for now for us. We've been very successful doing these procedures with the mini rail fixators, but it's not definitely the best option. So hopefully soon we'll have something for you guys. It would make it a lot easier for the surgeons also to operate.
Yeah, one more.
Let me see one more. So they're talking about, hello, is tibia lengthening with magnetic controlled intramedullary nerve within a podiatric scope of practice? Okay, so this is a good question. It's a very technical question. So they're talking about tibia lengthening, which is the shin bone. And there is a company that makes these devices, which is an internal rod. And the way you lengthen the bone, you put this internal rod inside the medullary canal of the tibia or the femur, and you break the bone at a certain level. And then you hold this magnetic device on your tibia or your femur on a daily basis, and it gives command to the rod to turn a certain way. So when the rod turns, it starts distracting the bone. So you don't see anything on the outside of the foot. Once you put that device on the leg, it gives it a command, and based on the programming, you can lengthen for whatever length as you desire, like 0.5 millimeter, 1 millimeter. So they're asking me, I'm assuming either this is a student or another colleague, podiatric colleague, foot doctor, is it within the scope of practice? You have to find out from your state's laws. If you are able to enter the joint, knee joint, in your state as a podiatric surgeon, then you'll be able to do it. But if you're like state laws in California, it allows me to go all the way up to the tibial tuberosity. That's just right below the knee, and I can do whatever I want all the way up there. But I cannot enter the joint, the knee joint, in the state of California as a podiatric surgeon. So in my state, I cannot enter that, and I cannot insert that rod, because the only way that rod is going to go into tibia is that you have to enter it through the knee. So if you're not able to enter the knee, then you're out of your scope. So you have to look at your state laws and see what your state laws allow you to do and not allow you to do. So hopefully that answered that question. It's a very nice device. I have used it in my fellowship. We've used different kinds. At the time, it was not available, but we used a different intramedullary lengthening device, which works beautifully. But I was working with under orthopedic surgeons in Baltimore, and we did that in the femur and the tibia. So it's an excellent option, but look at your state laws and see what that tells you. So I think we're pretty much done, and we're pretty much right on the schedule, 2 minutes early. I wanted to thank you guys for logging in and joining us. It takes a lot. It takes a lot to do these live events. If I were to show you guys what's happening behind here, how many cameras and lights and microphones and TVs we're using, you'd be shocked. But I'm happy to do it. I love doing these things. My goal is to help patients answer their questions and hopefully educate the general public. The more educated you are, the better decisions you can make. One advice I can give you, do not always jump to surgery with one consult. If you have any slight doubt or questions, get a second opinion. Foot surgeries can become quite troublesome if you have major complications. After all, you're walking on your foot. If you have any issues, long-term issues, it's going to basically affect your lifestyle. So always get a second opinion. Come join us on my live sessions, and I'll try to answer your questions the best I can. Hopefully we can do something fun soon. Not so much serious stuff, medicine and foot and ankle surgery. We're planning on doing something for fun. I do also have a channel called Life Limb Fitness, which is about my life, my fitness habits, and again, limb, which is part of my work. But I don't talk about work, but I just talk about how I go to work, how I conduct my business, everything besides the medicine part of it. So that's why I call that Life Limb Fitness. So I spend a lot of time doing projects at home with my dad, and my kids are always around. So that channel really reflects my side of being home, not at work. So work is Khosroabadi Institute. Everything else is Life Limb Fitness. We're going to have a live session on that channel soon. I will be interviewing some entrepreneurs and anyone that you guys, any subject you guys want me to talk about, I'll try to bring an expert and interview them. We'll be doing some fun stuff, maybe meditation stuff. I'm big into meditation, some coaching, life coaching, just life experiences and lessons. So I also have a trip that I take to Nepal on a yearly basis. We go to Nepal every year with the Healing the Children organization, and we operate on children with various deformities. Unfortunately, last year we have not been able to go because of COVID, and this year also was canceled because of COVID. But we go on an annual basis. So that's that event. That trip is very close to my heart. When it happens again, I will be sharing with you guys my journey. So thanks for joining us. I think this is a wrap, and hopefully you guys gain a lot of knowledge, and you got your questions answered. I'll be talking to you guys second Tuesday of next month. Have a lovely day, and God bless you guys. Thank you.